me introduce Dr. V. Sri, who is DM Endocrinologist and is a consultant endocrinologist at Sri Nagesh Diabetes, Thyroid and Endocrine Clinic in Hyderabad. He has major achievements to his credit. Very, very young, dynamic Endocrine Society member. He has achievements including the Y.R. Reddy Gold Memorial Award. He has a medal to that. He has S.V. Rao and M.M. Swami Medal, the best desertion for the year 2007. He has been adjudged as the best orator at TISA for his presentation on early initiation of insulin in type 2 diabetes mellitus. He is a fellow of 14th APPES, ICEPAD and ESPE Science Schools, Indo 2015 Early Career Forum at San Diego, fellow of the 24th EASD Scientist Training Course at Barcelona in November. Also a Anil Sheth Award recipient and has 24 peer-reviewed publication and 15 textbook chapters to his credit. May I request Dr. V. Sri Nagesh to speak further. Thank you so much.
Thanks a lot for the introduction, and it's always a pleasure to be a part of any program which is headed by such an eminent panel with very senior endocrinologists like Murthy sir, Dr. Thomas Pal sir, and Sanjay Bhadada sir. And I'd like to compliment the organizers of this program for trying to arrange a program with a difference. For the next 15 minutes, I'm going to focus on a subject in the management of type 2 diabetes, which has not often been touched. It has come into a lot of public attention over the past 5 to 6 years, especially in the two Telugu states. We have had a huge number of controversies regarding the fact that many endocrinologists and physicians are not really focusing on prevention of diabetes. We've actually been focusing more on the treatment of diabetes. There have been so many recommendations for a lot of fat diets, many of them which have been based on the keto diets, sometimes with disastrous effects, which has been brought into sharp focus further because of the increased risk of diabetes which has been seen in with corona in the last couple of years. Unfortunately, what the lay people are not aware is the fact that we've been doing a huge amount of research in the prevention of diabetes. But unfortunately, these results are not sustainable over the long term because adopting a healthy lifestyle is not all that easy. Second, we've not really been able to get a culturally appropriate diabetes prevention program, at least in the Indian scenario. And it's a fact of life that a majority of the diabetes cases are in Southeast Asia. But most of these diabetes prevention programs have been done in the West. And it is, as I'm going to delve further into my talk, it will come as a very pleasant surprise to you that we now have large-scale Indian peer-moderated diabetes prevention studies which have given very good results. This is what I'm going to speak about, what we have been doing for the prevention of diabetes, how we can bring technology into the prevention of diabetes, how successful are we, what do we need to do better, and do we really need to go for all these fat diets or keto diets? And lastly, this talk will emphasize on 3 particular areas. The first one is the prevention of type 2 diabetes. We're going to have some discussion on gestational diabetes, a little bit of focus on technology. A lot of the technology part has already been dealt with by Shashank Joshi sir, but I'm going to briefly touch upon it in the aspect of prevention and maybe a small note at prevention of type 1 diabetes, which was not an initial part of the program. But with the recent focus on tocilizumab, which has been rejected by ADA for the prevention of type 1 diabetes, I thought probably we should touch upon that briefly. And most of my talk has been from the abstracts of the ADA session because their endeavor is to bring to you what has been discussed in the ADA sessions as far as the prevention of diabetes is concerned. To set things off, I'm going to speak first, give you a brief overview of this, what was known as the Norfolk Diabetes Prevention Study, which was a study done by Professor Mike Sampson. This was a very large study which was funded by the UK NHIR. Almost 150,000 people were screened, and out of this 150,000 people, they were divided into 3 groups. At the end of the day, you picked out around 1,028 people. There were a few particular features with this study which were specific to Norfolk Diabetes Prevention Study, which had not been done with the earlier studies. Most of the earlier studies had actually focused on people with impaired glucose tolerance, raised postprandial blood glucose levels. The Norfolk study actually divided people into 3 groups. One, people without diabetes who were in the second group, people who had an impaired fasting glucose, and contrary to what is seen with the other recommendations, their definition of impaired fasting glucose were people who had a blood glucose level more than 110 and a blood glucose level who had which was less than 126. The traditional definition of IFG is 100 to 125, but in this study it was 110 to 125. And they had another group, non-glycemic high-risk diabetes group, those who had an HbA1c between 5.7 to 6.49 and a fasting blood glucose less than 110. We actually did not have an impaired blood glucose group in this particular study. And then these people were then randomized into three groups. One was a control group. One was a group where we had a standard intervention. And the third group was where we had a standard intervention along with a volunteer group, which emphasized the advice of the standard intervention group. And they were known as the diabetes prevention mentors. So this was what they wanted to see, whether addition of these diabetes prevention mentors could add anything extra to the diabetes prevention study. What they actually found out at the end of the day was, when compared to the control group, the ones with the standard intervention as well as the ones with the standard intervention plus the diabetes prevention mentor had a 47% reduction in the risk of progressing to diabetes. Many of them actually regressed to normoglycemia, and a lot of these people had a weight loss which was approximately in the neighborhood of 3 kilos. So what this actually translated to do was that it reiterated and re-emphasized what has been seen in the other diabetes prevention studies. You go in for a lifestyle and exercise of almost 150 minutes per week. You go into a diet which is pretty similar to what you'd see with the Mediterranean diet, cut down on your saturated fat, lower your carbohydrate content, lose your weight of up to 3 kilos. It reduces your risk of diabetes. A lot of these people can regress back to normoglycemia. And what they actually found out in addition was that this diabetes prevention mentors did not add anything much to what had already been done by the standard intervention group. The conclusion of Dr. Sampson was that these people, perhaps in the adult group, were not very useful, but in the younger children and the youth who have less motivation, the DPMs could probably play an important role. Coming to the final outcomes of this study, I had a couple of observations. The first observation was, this reflects what has been seen by a majority of us in the other recent app-mediated diabetes control programs. A lot of these app-mediated and digital-based diabetes control programs put these patients on 2 to 3 months of very strict diet and lifestyle. A lot of them go off their medications. They regress to normoglycemia. And this has been considered a case of diabetes reversal. But we have to understand that what has been emphasized by the Norfolk study is that it is a short-term regression to normoglycemia. The challenge is not in getting to a short-term regression in normoglycemia. The challenge is in maintaining this weight loss, motivating people to continue this physical activity, and eventually ending up with long-term normoglycemia. And unfortunately, that has not been seen in a lot of studies. This is our biggest challenge as far as diabetes prevention is concerned. And if you are a part of such a diabetes reversal program and you've achieved what you'd consider a diabetes reversal, don't rejoice too soon, because maintaining it in the long term is the difficult part. The second critique of this Norfolk diabetes prevention study was that it essentially looked at people with impaired fasting glucose and not at people with impaired glucose tolerance. As has been seen by a lot of us, most of the diabetes studies have actually looked at IGT, and we've had good outcomes in people with IGT as far as diabetes prevention and prevention of progression to further and worse diabetes is concerned. But unfortunately, that has not really been replicated in the Norfolk study, and their definitions of what constitutes IFG and what constitutes a normoglycemic high-risk group is a bit sketchy. So we need more people, further definition and more long-term data before we can really conclude that this Norfolk diabetes prevention study gave us something really concrete. Coming to the next section of the ADA talks, we had one talk: can we prevent type 2 diabetes in women who have gestational diabetes? This was essentially based on a meta-analysis of 20 studies which involved almost 250 women. What all of us know is that women with gestational diabetes have greater risk of progressing to type 2 diabetes, almost 10 times greater risk as is seen in the normal population. This particular group has been seen by almost all of us, and they have an almost 40 to 80% risk of recurrence of GDM in the next pregnancy. It's almost considered de rigueur that if you've had GDM in one pregnancy, you're likely to have a GDM in the second pregnancy. And most of the data which was actually mentioned in the study was obtained from the nurses' health study, because the nurses presented a group of people who are easy to monitor and who are likely to be followed up for a longer period of time. And in this particular group, all those nurses who had healthcare professionals who had a GDM, when they were started on 100 minutes of physical activity per week, approximately 100 minutes of physical activity per week, as little as 100 minutes, there was a 9% reduction, lower risk for type 2 diabetes after gestational diabetes. And if this 100 minutes of exercise was increased to 150 minutes of exercise per week, there was a 47% lower risk of progression to type 2 diabetes. What it actually tells us is, once we have a woman who's come to us in the OP with GDM, they go for delivery and then they don't follow up with us again. They just come back to us again only after they've developed type 2 diabetes, or they have a second pregnancy and they've again had a recurrence of GDM. We do keep emphasizing to them, we do keep telling them that you are at risk of diabetes. You need to buck up after your pregnancy. But unfortunately, this message is not translated to the gynecologist. This message is not translated to the pediatricians. If we can succeed in creating in them an awareness about the risk of future type 2 diabetes, and if we create in them a perception that they're overweight and they need to do something about their weight. In all these studies, when women were perceived that they were overweight, there was more motivation to indulge in more exercise and in having a more controlled diet. The other part where we actually fail in a lot of our patients is in telling them that after they have delivered, that is not the end of GDM. GDM does not disappear automatically after you're delivered. You have to continue screening yourself. And if you're screened at 6 weeks and 3 months after delivery, and at least every 6 months subsequently, and you find out that you have elevated blood glucose levels, contact your doctor, start your lifestyle changes. Unfortunately, these three messages are never brought across to these people. And this is what ACOG, the American College of Gynecologists, has been telling their patients and their gynecologists repeatedly. Make sure that the patients receive appropriate information, refer them for testing wherever required, send them or refer them to the appropriate specialist, and also recommend weight loss. Unfortunately, in a country like India, we have a huge amount of family pressure. Everybody gives you advice except the doctor. And pregnancy is considered a state of nutritional deprivation. And once you deliver, irrespective of your glycemic status, there is a tendency towards giving them tendency to overeat, give them more calorie dense, and give them less nutrient dense food. And unfortunately, this is what pushes them from the border of prediabetes to diabetes. And that is the point where the recent studies, and this particular study, have emphasized on a point known as care coordination. There are multiple definitions for care coordination, but in the long term, what care coordination actually means is it synchronizes the delivery of a patient across various healthcare providers and specialists. I'll give you a typical example. You have a woman with GDM. She has come to you for control of diabetes. She goes back to the gynecologist. She delivers. The problem she is going to face after this is she might continue to have diabetes after delivery. She might have an infant with gestational diabetes who has infant of a diabetic mother who presents with hypoglycemia in the first 3 days of life, who is shifted to the pediatrician, and consequently this woman does not breastfeed, which again increases the risk of a gestational diabetes. What this care coordination actually does is it coordinates between you and the gynecologist. You tell the gynecologist to test the patient for diabetes after pregnancy, keep on monitoring her. Coordinates between you and the pediatrician and the gynecologist. You tell the pediatrician that he has to monitor the child for hypoglycemia. You tell the pediatrician that this mother has to breastfeed irrespective of her current status and irrespective of the status of her child. Except if he's having seizures, it is always mandatory to institute breastfeeding, because if you don't breastfeed in the first 3 days of life, it's very unlikely that you're going to continue breastfeeding later on. And also coordinate between the three specialists here, the nutrition and the dietitianist and the exercise specialist, so that we continue this care program even after the woman is delivered. And one important aspect, two more minutes. And one other aspect which people focused about was doing this kind of activities in a country like India. We had two programs, the most important of which was the Kerala Diabetes Prevention Program, which was a program which was tailored for an ethnically appropriate population group, where you had small group sessions which were led by peers. one session approximately every week, followed by a couple of expert sessions. And what was significant to this particular intervention program was that you had a coordination between the community, the peer group, as well as the expert, which is most important for a for ensuring that you have a long-term diabetes prevention program. The second program which we had was the Smart 2D program, which had a peer support program and a care companion. This was a program which was carried out in Africa, Eastern Asia, and parts of India. And both these programs actually said that when you had an ethnic fit, diabetes prevention programs could be carried out in people in India also, or in countries which have lesser resources but greater prevalence of diabetes. Coming to the technology part, I'm not going to speak more about it because that has already been emphasized well by Dr. Shashank Joshi sir. But what I'll tell you is, like sir has said, WhatsApp, apps, messages have become very important in the monitoring of diabetes. The single largest problem we had in monitoring our patient, following up our patients, was the fact that they were not reachable. Transport has become a problem, and especially in the setting of the lockdown and the digital communication, this is no longer a problem now. We can reach out to our patients, we can monitor them, we can have support groups also on WhatsApp, we can have messages going on back and forth between you and the patient, which you can answer at your leisure. And technology has actually made reaching out to your patients a lot more easier, even though it also comes out with its own different problems. And lastly, one little note on the recent tocilizumab issue. In people who are at risk of diabetes and who are already on the path to type 1 diabetes or have been recently diagnosed with diabetes, there were a few studies which actually looked at the immunomodulator, the monoclonal antibody tocilizumab, which actually reduced the beta cell destruction by the autoimmune diabetes mediated activity. And in case you had people who were going to progress to diabetes, it could delay the progression of diabetes. And in people who have already been diagnosed with type 2 diabetes, tocilizumab was actually found out to reduce the beta cell destruction, if possible, obviate the need for insulin therapy or at least reduce their insulin requirements. And subsequently, tocilizumab was brought up before FDA for approval. In a surprising move, FDA voted not to allow tocilizumab into general use for the prevention of diabetes at this point of time by a matter of, I think, 1 or 2 votes. But they've still gone back to FDA. FDA has not given any particular reason why they have rejected tocilizumab. They've again gone back to the drawing board. I think we are going to come up with a few more answers a couple of months down the line. And in a couple of years, all these days we've been speaking only about prevention of type 1 diabetes, of type 2 diabetes or gestational diabetes. But speaking about prevention of type 1 diabetes might also be a reality very soon. That's it, and thanks a lot for the opportunity.